If you have a question you don't understand, just put up your hand. This is not the one that will wait till the end. If it's cogent, chances are if you have a question, other people have the question. They're just afraid. If it doesn't make sense to you, it looks like jaga jaga completely. Just say, please, I didn't see it. Do you understand? If you are true with me like this, you will learn. Okay? If you are true with me like this, you will learn. Don't worry. If you can see, you can read an ECG. We'll do it in 90 minutes, maybe plus extra time. Okay? I mean, there's extra time in football now, not be so. But we'll do it in 90 minutes. So, over the next 1.5 hours, what seemed impossible will become possible. All right. One of my friends used to tell me, he told me that when we're going for final exam, that if they ask ECG in the exam, he will say, don't worry, I'll come back. Like he would not even try. And luckily they didn't ask him, so he's the doctor today, but he cannot read ECG today. And there are many doctors like that. Okay? But that's not the case. If you are a healthcare worker, everybody, ambulance drivers, anybody, you should be able to read an ECG. Nurses, physiotherapists. If you cannot read an ECG, it's really bad. Some people are working in theater with monitors and they cannot read it. They're just looking at it like TV. Bing, bing, bing. So what is happening? That's not good enough. So when we're talking about sudden cardiac death, one of the bedrock is that you can read an ECG. If you cannot read an ECG, you cannot do ACLS. So if you fail this course now, the next course, just go. Tell them you don't want your certificate again, that you don't do again. Okay? Fine. So I'll give you enough introduction. My name is ISEKO. I work with CardioCare as an interventional cardiologist. Okay, so first things first, these are the 5 rules. Well, there are 6. Number 1, believe you can. If you're already here and say this is not for me, don't worry, just go in peace. Don't bother yourself. It will not work. Number 2, you must write. If you're not writing, you're wasting your time. Please don't even stay near me so that you will not discourage me. Go to the back. Okay, you must write. You must get a pen and paper and write. If you don't do these things, you will not read ECG today. I assure you. Number 3, we need to practice. We need to practice and practice and practice. Number 4, there are some things you must memorize. There are some formulas you cannot just say, okay, you know it. No. So you write it down, you memorize it. When we come to practice, you will now ask. Number 5, keep the understanding of the ECG, of the heart. So in your mind, you need to picture the heart anytime you're reading an ECG. And I'll show you how to do that. Every time you do an ECG, picture your heart. Especially the more complex it looks, just picture the heart in your mind. Please get them chairs so that they can sit down. So they don't get, I'm turning to, they should do some exercise. Number 6 is not here. Catch somebody else and teach. Catch your 12-year-old son. I'll catch my 12-year-old son and teach. Those medical students that were medical students, some of them are consultants today. When I was an SR, I think I met some consultants that were saying they were my medical students. Oh my God. Selayo, you must understand. Till 8 p.m. we are there. Because what I learn, once I teach, I know more. Right? Same thing here. Catch another nurse. Catch somebody. Catch your gate man. Do you understand? Tell them to be nothing. I'm serious. This is very key. Very, very key. Number 7. When you finish, you need to go and practice. You need to do at least 50 ECGs between now and Monday. If you do not, you will forget. You will not read this ECG again. And if you do, you will always, for the rest of your life, know how to read ECG. This is the promise I make to you. If you don't follow these 7 rules, you will not read ECG. Next year, you will come back and say, this thing is something where I know. Beautiful. So, get your pen, your paper, and write. Don't say you're using the iPad. iPad will not work here. Write. Don't say you're typing in your phone. It will not work here. Just believe me. If you could read this before, you will not be here. So now believe my own. You tried it and it didn't work. I will show you my own. All right. So what is ECG? It's a cheap, widely available tool, an electrical interpretation of the heart. It's also available, helps us to see non-cardiac conditions. But particularly, it helps us in patients with cardiac arrest, in prevention of sudden cardiac arrest, in cardiac conditions. It's invaluable. Nobody that has hypertension should not have an ECG. It's an aberration. You did not come here. If anybody has hypertension, they must have an ECG. If anybody has any cardiovascular condition, they must have an ECG. If you are 40 and above and you have a picture and you have an ECG, you are not serious. Instead of the birthday shoot, pass my CardioCare and have an ECG. So having your, I know I just do your face like this. What's the meaning of that one? Say a grown old man does not have an ECG. Not correct. All right. So also useful in treatment of that. So some of us, this is how we look at it, Abi. Huh? Now all of them just jaga jaga. Don't worry. Today, that today. If you don't read it today, come and collect money from me. But don't lie, you. So the first thing is that the lines are divided into 1, 2, 3, 4, 5. 5 parts. P, Q, R, S, T. Period. Write it down. I'm telling you what you need to write. There's nothing I'm going to say. These things I will say in these first few minutes. Those people that went out, when they come back, they will never understand ECG. Trust me. Anybody that comes after this first introduction, they will not understand ECG again. So you need to remember that this is P, Q, R, S, T. There's also U, but leave it. Oh, another rule. Any half knowledge you had before, forget it. Just listen to what I'm telling you. All those half things, all those advanced things that are made not to be able to do ECG, forget them. Just learn this simple one I'm teaching you now. All right. I've simplified it further. It's a little bit different from what I've taught in previous years. I've made it a little bit simpler. So, let me see. Yes, thank God I have it. So like I said, you should have this diagram in your heart. The P wave is, we can see the atrium and we can see the ventricle. Every time cardiac activity is happening, the atrial node, SA node, depolarizes, right? Can we see that? That blue area depolarizes. It gets an impulse. That one is not normally seen on the ECG. The next thing that happens is that impulse goes round. See those green fibers? It goes round the right first, then it goes to the left. After it goes round, that causes what? The P wave. Don't forget it. P wave is atrial depolarization. Remember, you are going to have to remember these things when you are interpreting ECG. So when I get more complex, this is what you're going to remember. P wave is atrial what? Depolarization. After it has gone through the atria, it now comes to that yellow spot, which is the AV node. That is customs. Sorry, are there customs people here? Yes. Sorry, customs. I'm going to use for example. That is customs. They just stop and delay your goods from entering the country. But there's a good reason here. It doesn't want all the different things to be entering from Seme, from different borders. Everything should come and enter from one spot. That is the AV node. So it causes a delay at that point to gather all the activities. All the one that has gone through the right, all the one that has gone to the left, let them all come together and enter. Then it will pass it down. AV node. That causes a delay. That is the difference between P wave and this PR segment. That is that AV node. You can see nothing is happening there, Abi. It's flat. PR segment. That represents that AV node. So the P wave is what again? Atrial. Thank you. Then it now goes and waits at customs, Abi, to enter AV node, Abi. AV node is represented by what? PR interval. Meaning whenever there's a block at that AV node, it will delay much more. Right? Very important. We're going to get more serious. The next part now, it has finished that waiting. It now transmits it to the ventricles. The ventricles now depolarize. So QRS now is what? Ventricular depolarization. It goes down these Purkinje fibers, his bundle and Purkinje fibers, and goes to the right and to the left, causing the QRS complex. Is that clear? Isn't it easy? It's not easy. I should come again. Okay, fine. We start from the beginning. It starts from blue. When blue is getting depolarized, we cannot see it on the ECG. The special kind of ECG, we put wires into the heart. In the electrophysiology study, is on that one we can see it. But what we are doing outside, for this purpose, you cannot see it. Then it now sends electrical activity. The process of sending electrical activity is called depolarization. Is that depolarization that will send the thing will now contract. That's depolarization. So that causes the P wave, right? Do you understand that so far? Then it now waits at the yellow point called the AV node. That represents what on ECG? PR, correct, beautiful. So it's now there waiting. Then it collects and goes down and goes to the left and the right part of the lower part, ventricles, I mean. And what causes, and what does it show the ECG? QRS. So what do you want to understand inside again? It's easy like that. Don't stress yourself. Remember one of the laws. Forget all the half knowledge you had before. It's what is jamming your head now. Leave it alone. If you follow that one, you would have read ECG before. Just this one I'm saying. Now it be the truth. That one, now it be lie. Is this clear so far? Beautiful. So, if we have a blockage at constant, what will happen? Which part of the ECG will change? PR. PR will now get longer and could be misbehaving. If we have a blockage somewhere along the His Purkinje fibers going down on the ventricles, where will it prolong? QRS. Is it not easy? If the atriums are very big, what will prolong? P wave. What else again? You are reading ECG, you sign it and then tell them to pay you 5K. ACS graduates. You are your own. All right. Very simple. So we have gotten this one. So in your mind, you should keep this in your head. We're going to use this knowledge when we go forward. We have 90 minutes. We'll never enter halftime. We are still making substitutions like Enzo Maresca. All right. So we've talked about this. Now the next thing I want you to know is that we have parts of the ECG besides all these PQRS. So different combinations come together. We now have parts we call intervals and parts we call segments. Intervals and segments. Good. For intervals, we are measuring time. For segments, whether it's going up or down. It's easy, it's too easy, Abi. Very easy. I can see CardioCare as like this thing below. I get ECG for you. You don't go answer that today. All right. So what do we say about intervals? What are we measuring in interval? Time. What are our segments? Is it up or down? You can see a 2-year-old can do it. So far you know what is up, and so far you know what is down. Okay, now. If you look at this QRS, is it predominantly facing up or facing down? Up, Abi? This P wave, is it facing up or down? T wave, uncle? Shikena. So what Dr. Adefila was telling us about was ST interval. Can we see the ST interval and then we have an ST segment? Can we see the J point? Can we see where J is? Where that place is? So when that one is up, we say it's ST elevation. And the person has chest pain, we say ST elevation MI. You don't become a cardiologist already. All right. And if that that ST segment is down, we call it what? ST depression. Oh no. Beautiful. So this one you have to write. Remember I told you there are some formulas you have to cram. This is one of them. For every part of the heart, let's assume this podium is the heart. And the voice of two witnesses a matter is confirmed. Okay, I can see Pastor Bibama he's hearing how he can confirm doctrine in scripture. Before we can say this is red or this is red, two people from this angle and from this angle at least must confirm that it is so. Right? So, also in the ECG, you must have at least two contiguous leads that are looking at the same area. They must agree on certain things for you to agree that something is happening here. That's what we call contiguous. So the ones that are looking inferior are lead 2, lead 3, and AVF. Lead 2, lead 3, and AVF inferior. It's not a snappy matter. Write it. I know what I'm saying. Write it. We've snapped. It didn't work. Now for lateral, it is 1 AVL V5 V6. 1 AVL V5 V6. For anterior V3 V4, septal V1 V2, depending on who you are saying. But like Dr. Adefila told you, it's very rare to see one of these. Most times, both anterior and septal will happen together. You can see V1 to V4. You have to cram. So like I told you, there are some things you must cram. And you must write it down. What we do is simple. You write down all these things I've said. Then when we start interpreting ECG, we'll just bring out the book and using it. Bam, 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 bam. After the ACS, hopefully I have enough time, I will send you a link to do a small test online. Not for anything, just for you to practice, to see that you can do it. All right, so now we have learned the basics. Oh yeah, let's start. We are going to use this template to read ECG. Newer template, shorter. Number 1, identify the name and calibration. Number 2, rhythm and P waves. Number 3, QRS. Number 4, ST segment, Q waves, T waves. Okay? So, number 1, let's identify the ECG. Very simple. Make sure you are looking at the correct ECG. People have referred the wrong patient. Acute MI. The name is different from the patient that we're looking at. You can kill somebody. So number 1, make sure you look at the correct ECG, the correct name. Check that the proper speed and proper. Sometimes people, because they change the calibration of the ECG, instead of 10 millimeters to 1 volt, they reduced it. So what was S elevation now looked as if it was normal, because it's now shortening it by half. So it did not look as high as it was. So you need to know the ECG and know the calibration. Number 2, we check the rate. So Dr. Amina brought out a case of a rate of 180. 180. Please pardon us. I'm not sure. We might have to jump the program a little bit and just do some things and leave some other things, because it looks like we're hard fought for time, and I want you to make sure you get some things home. Not that we finish the whole program and you don't get anything. So there are some things you must get. So when we want to know the rates, we do 300 divided by the number of large boxes. So we take the interval between a QRS segment 1 and 2, just any of these ones. We take a segment in between and find the number of big boxes in between. 300 divided by that will give you the rate. Is that not simple? Hello? Simple, Abi? Repeat. Count the number of big boxes between one QRS peak and the other QRS peak. Do 300 divided by that number. That will give you the rate. Okay? Very simple. So let's look at this. What is the rate here? What is the rate here? What? 150. You don't understand. See consultants around you. You don't understand. You do not see it well. Just either use your hand or just point to somebody quietly. Dr. Inuwa is here. Dr. Taiwo is here. Dr. Adifila is there. Lolo is there. Just point to any of them. How many people cannot see that it's 150? So what do we do? How can we see it? We looked at the number of spaces between one. So how many big boxes are between here and here? 2. 300 divided by 2 is? If it were 3, what will it be? If it was 1, what will it be? You see, you don't read ECG now. Is it hard? It's not hard. Is it hard? At all. At least for now, Abi. Alright. What about this one? This patient, 48-year-old, came with lightheadedness some days after starting a new medication for hypertension. What's the rate? Eh? 20? 50. How did you arrive at 50? We have cardiologists here already. Genevieve, like cardiac anesthesiology, all right. All right, so the next thing now, we are finished with rate, Abi. You don't understand it, ma? You need explanation. Should I go right again? Should you go right again? Okay. So how do we define the rates? We simply come here. Hello? I'm saying for those that didn't understand. We come here and we see, can we see the big boxes? From here to here is the big box, Abi? So we try and find, we can see these QRS peaks, Abi. Can we see them? So we'll now look at it and say, okay, which ones fall on a very good line that we can measure? This one falls almost on a good line, Abi. So how many big boxes are between here and here? So 300 divided by 2 is what? That's how we arrived at 150. It's not exactly, there's one small one here, there's one small one here, so maybe divided by 2.2 or something. But generally, that is a rough thing. So when we came to this one too, we came here too, we say, what is it? From here to here, how many small boxes are there? So we say, okay, maybe 1, 2, 3, 4, 5, 6, something like that. So we say 300 divided by 6 is what? 50. That's how we arrived at it. Is that clear now? Is there anybody that's still not clear for? Good. At least don't tell me. All right, so the number 3 now, we are going to P waves. So check the rhythm and P waves. Very important in this ECG. There are no P waves in this ECG. Can you see any P waves? Very important. Dr. I mean that your ECG is not normal. The one after it came down. It's not normal. So we have 5 rules. These rules you must write to determine whether it is a sinus rhythm or not. You're not writing. We have 5 rules to determine whether it is a sinus rhythm. We ask all 5 questions. Even me, I ask it. When there are some ECGs that you see like this, it will just scatter your head. I just go back to these basic questions. Whenever in trouble, just go back to basics. And I go back to these basics. Every year I'm teaching more people, I am getting better at ECG. So number 1, are the RR intervals equal? So we can see RR interval, Abi. We know what PQRS is, right? RR. So we know what R is. This is R, Abi. This is another R. So the distance between this one and this one and the other one and the other one, are they equal? Relatively equal, Abi. So that's the first question. Are the RR intervals equal? The second one, we know what upright is. This P wave, is it upright or upside down? Upright. Perfect. Is it upright in lead 2 and inverted in lead AVR? I've not reviewed this in a long time, these slides. So the third question we ask is that every time we see a QRS, was there a P wave before it? And every time we saw, the fourth question, anytime we saw a P wave, was there a QRS after it? It looks like the same thing, but it's different. It's very different. When we get to some complex ECG, you see why those 2 questions are important. You just walk with me like a nursery child, and you read ECG. If you know too much, you no go read. All right. And number E, all the P waves, are they similar? Or is there any away match? All the children that we are seeing now, do they all look like they came from the same person? Is that clear? You're writing, right? So we said number 1, RR interval is regular. Number 2, P wave is upright in lead 2 and upside down in AVR. Number 3, all the QRS. Before them, there was a P wave. And after every QRS, is somebody just jamming? Before every QRS, there's a P wave. And after every P wave, there is what? A QRS. We said there are different questions. And then number E, we said all the P waves, do they look alike? Do they look alike? So, let's now take it. I need people. Where is Jude? Bring Mike, bring Mike. I don't have a person with Mike. I want some bold people. The people that normally attempt to answer questions, they always read ECG. As in they continue reading ECG. When they are sending us questions, they are answering questions. The people that sit there like this and say, nobody will try me. You are your own too. Now, so you go look at ECG to that day, you go say, Kai. Fine, so make sure you try and attempt. So, is this a sinus rhythm or not? So go back to your notes. Question 1. What question 1? R interval, are they equal? Yes. Good. Question 2. So every QRS, is there a P wave before every QRS? Yes. Right? After every P wave, is there a QRS after? Yes. Beautiful. Question X, Abby. Lead 2 and AVR. Is it upright in lead 2? Yes. AVR, is it upside down? Yes. Correct. And the final one, all the P waves here, do they look alike? Yes. Bam. So if you take out your ECG now and look at it, you will now find that Coco, it's not normal at all. I saw it, I just laughed. All right. So now I need somebody to answer this one. You must try. Is this sinus rhythm or not? Yes, yes, anybody?
Okay. No.
Okay, so how do you know?
The PR intervals, the intervals are not equal. The RR intervals, rather.
Ah, that was not equal. What
Yes,
else
they are
is
not
there?
equal.
Okay. What are the other questions?
Okay, the other questions, is it upright in 2 and inverted in AVR? Yes, it is.
Where did you see it?
That's lead 2, that's
Where did you see
AVR.
the Q wave in the two?
Okay, no P wave, yeah, no P wave in lead 2. No P wave.
Did anybody see P wave there? There is none. If you saw it, Ali and the angel. There is no P wave there at all. So the RR intervals are not equal, right? And then the P waves, we cannot even see them. So all the other questions are gone. Automatically, we have QRS with no P wave before it. Not so? So we have failed 3 questions. So this is not. So what rhythm is this one? What rhythm is this? It's an abnormal rhythm. That's very correct. My son knows that too. But what rhythm is it? Yes.
I'm trying to identify the P waves. The P wave in the rhythm 2, the long strip. I'm seeing some parts as if there's actually a P wave, but some parts is absent.
You are correct. She's actually correct. Because if you look carefully, like she has, you will see that there's one small P wave here. Can we see that?
Yes, sir.
Small one. Then this one looks upside down, like it went down. There's a P wave definitely here. And then a small one here. Then it now goes absent. Then it shows up there. And it shows up there. So she's actually correct. There are some P waves. Can we see it or we can't see it? You can see it. This is now critical looking at it. But it's still abnormal. Those P waves that all scattered, they are abnormal. In this case, we take it as we cannot see P waves in most of them. So when we cannot see P waves and the RR interval is abnormal, we call that atrial fibrillation. We call that atrial fibrillation. It's in this your paper, I think. Yeah. Is this your paper? If you check your bag, there's this paper there. This paper is your friend. Paste it on your roof while you're sleeping. This paper is your friend. You will see number 1. You will see all those questions there. And then it says absent P wave with irregular QRS, atrial fibrillation. All right. Ma. Okay.
For turbines, jaga lines. The first one is written 1, then we have 2, before 3, before we have rhythm 2. So
Okay.
which one is the 2?
Thank you very much. Thank you. I love that question. Some people were thinking it. So we call this a rhythm strip. We call this a rhythm strip. It is the same as this rhythm 2. But what we did was to take this one for a long period so that we can actually tell the rhythm. Because this period may be too short for you to tell whether it's all equal, whether all the QRS came afterwards. This is too short, Abi. Because just 3 or 4 beats here. So the reason we have this long, also we can see all the QRS. Is there a P wave for every QRS? Is there a P wave? We need this long one. So this is called a rhythm strip. So it's the same as lead 2 here. It's just that we spread it out for a longer period. In some ECGs, it will be all of them will be long like that. When the case is complex, we turn our computer and make all of them to go long like that so that we can see. This thing we saw, was it really there? In the other leads, we start comparing. So yes, it's still the same lead 2. It's just that it came out long for us so that we can truly count the rhythm and count the distance. The question I want you to ask, yes please.
This was 6 seconds straight.
Yes, typically 6 seconds. Typically 6 seconds. Some ECGs are different. Some people are longer, some are shorter. So the next question I want you to ask, I thought you would ask, is what is the rate here? What is the rate here? Because we had a way of calculating rates before, Abi. This one now is irregular. So, go on. Yes? Anybody? Give her. Huh?
So we count the number of R in the long strip and multiply by 4.
By 10. Since it's
Okay,
6
by
seconds.
10. Okay, yeah, by 10.
So that is one way. This is like counting pulse for 6 seconds, right? So every one of these, imagine is a heartbeat, and then multiply it by 10. It's counted for 6 seconds, right? So you multiply by 10 to get the amount in a minute. That will give you, that's one way. The other way is to take an average of the RR intervals. So here is about 4, Abi. Hello? First one to second one about 4, Abi. This one about 2. This one about 3. This one about 2. Take an average. The average is about 3. 300 divided by 300. So you will now say the heart rate is 100. So you can take an average of the RR intervals of the RR box and do 300 divided by that average. Is that easy to understand? You don't understand? Raise your hand.
The RR intervals that you are going to be taking, are they like the 3 consecutive ones?
Anyone, just take an average that you can see that is on average. What is the average number of boxes in between? Or if you can, you start counting all the difference. Otherwise, the rate in between the other way you can do it, that rate between 300 divided by 4 is what? 75, Abi. 300 divided by 2 is what? 150. 300 divided by 3 is 100. If you take all of them too, and you add and divide it, you will still get the same average you are looking at, and you get the same thing. So beautiful. So let's go forward. Getting more serious. Is this sinus rhythm or not? Yes, I need somebody. Somebody to answer. Brave person. If you look away, now you have a call. If you are looking at me, I will not. If this man is trying to look at me, no work.
I don't understand. No idea. No idea.
Try.
I have no idea.
Just try. Hold the microphone first. Hold the microphone first. Just hold first. As you hold now, number 1 question. Are all the RR intervals equal? Anything you try, you can get. Just follow my questions. Okay. Look at this RR. Do they look equal?
Yes, they are.
Good. Question number 2.
The P wave, is it upright in lead 2?
Is it upright in lead 2?
1, 2, 3. Yes.
Lead 2. See lead 1 there. See lead 2. Is it facing up or facing down?
It is.
Okay. In lead AVR, is it facing down or facing up?
Lead AVR.
AVR is facing down.
Yes.
So that is okay, Abi?
Yes, it is.
It's normally supposed to be facing up in lead 2
yes.
and facing down in AVR. Good. Question number 3. You see, it's not hard. Once you try, Abi, it's not hard. All right.
The QRS.
Every QRS, was there a P wave before every QRS? There, look at that rhythm strip, all the long lengths.
There is a P wave.
There is a P wave. After every P wave, is there a QRS?
Yes.
After every P wave, QRS, Abi?
Yes, there is.
All the P waves, they look alike?
They look alike.
Good, so all your answers are positive. So what is this sinus rhythm or not?
It's a sinus rhythm.
You see, you can. Believe you can. Yes, we can. When I contest for president, that's why I got the shouts. Yes, we can. All right. Don't play this video that time. I go deny her. All right. Who go try this one? Who will try this one? You pick anybody. Anybody you like or not. Thank you, ma. Should we clap for you? Give microphone on our face. Put microphone on our face.
A round of applause for
Thank you. Just try. Last we will laugh. All right.
The RR intervals are not regular.
Exactly. So already we're already close there.
Yes.
There are P waves before the QRS.
Correct.
And I think there are some missing QRS complexes. Or no, it's just a prolongation.
Just follow what you know. Yeah, bring what you don't. What you
No.
The question number 2.
Okay,
P wave in lead upright.
Yes. In lead 2, yes,
Upright.
it is.
In AVR, is it upside down?
Yes, it is.
Good. Question number 3. After every P wave, is there a QRS?
After every P wave, yes, there's a QRS.
Before every QRS, is there a P wave?
Yes, there is.
Good. Question number 5. Are all the P waves similar?
No, they're not. They don't look similar.
Correct. You can see. So now, what rhythm is this? This is now where we are now getting...
An abnormal reading.
Correct. Yeah. All right, so now let's think about it. Put the heart in your mind. One of these, the P waves are looking alike. Where does P wave come from? Atrium, right? So when it comes from the normal place, it will look in one way. When it comes from another place, it will look, you know how all children can be yellow, then one goes black. You know that the wife did something, Abi? Now so this one be. Abi? Hello? This one and this one, they look alike. This one and this other abnormal one, they also look alike, Abi? The same gate man. Can we see? All these ones that came before, they all look alike. And the other set also all look alike, Abi? Two husbands. Is it not clear? Hello? Is it not clear?
Yes, sir.
Good. So we have this one. We have this one that looks abnormal. Looks like in head get oblong. This one again. This one too. Get ogo. This one, that one also get ogo, Abi? No be so? Same person. So if you find anybody that has ogo in your compound, Naim. No be so? Fine. So this we call an ectopic atrial rhythm. There's another point in the atrium. The same point that is sending its own. When this one sends, it goes send it own. When this one sends, it goes send it. The same point. So this is an ectopic atrial rhythm coming in between. And you can see it from the same point. In some places, it will be multifocal. So you'll be seeing different types coming. Different types. One get ogo, one get this one get game, one, you get it. We know that the away match is plenty. That is called multifocal atrial tachycardia. But in this case, this is unifocal from the same point. Okay, is that clear? It's not a sinus rhythm. It has already failed those questions. It has already failed 2 questions. It's not regular, and then the periods are not similar. So it's not sinus. Once any of those questions are negative, it's not sinus. The question now is now, what is it? So in this case now, we know it's coming from the atrium, and it's coming from a particular point over and over again in the atrium. These are real ECGs, though. These are not manufactured ECGs. These are ECGs from CardioCare. Some of your patients that have hypertension, you have not done ECG for them before. They have these things, they are walking around. All right. So, if it is regular, if it is not regular, and there are no P waves, that is what? Atrial fibrillation. Not regular, no P waves, atrial fibrillation. It could be regular or not, fast or slow, but you have multiple P waves before you have a QRS. 1, 2, 3. So in that case, before every QRS, there will be a P wave. However, after every P wave, there will not be a QRS. So you have P wave before QRS. That we call atrial flutter. Hello? Does that make sense? It don't make sense. Raise your hand. It don't make sense, Abi. So sometimes we have P wave, then QRS. P wave, then QRS. Then sometimes we have P wave, then QRS. P wave, then QRS. That's what we call atrial flutter. Then sometimes we don't even see the P wave at all. And the QRS are just coming scattered. Atrial fibrillation. Perfect. That's what we're talking about. Then sometimes, both the P wave and the QRS, there is no relationship between them. P wave come anytime, QRS come anytime, P wave come. There is no particular pattern to how they are coming. We call that a complete heart block. Most times, in that complete heart block, the heart will be slow. That person needs a pacemaker. Fast. Most of those people will be collapsing. They will have collapsed in your church, collapsed somewhere. People will do something. Don't just say, like somebody was telling you, that they tried propranolol, it was not working. You give that person propranolol, you will kill the patient. The patient will die. Because that's managed one. It will further slow it down to like 15. We saw one Baba one time. The heart rate was 20. He will collapse. There's one patient that they even declared dead. They are declared dead already. Before somebody say, wait, oh, there's something coming, boom, once in a long time. And the man is alive today. Quickly put pacemaker. It was like 15 beats per minute. So people already say that he's dead. Okay? So you will see that one. But normally, what would have happened? Months before he would have done an ECG, somebody would not have noticed that the P wave and the QRS are not come together. And then when it is very fast, wide QRS, bizarre and very fast. Typically, we call that ventricular tachycardia. And when it looks like jaga jaga, and you are sure it's connected, typically ventricular fibrillation. Ventricular tachycardia and ventricular fibrillation are emergencies. That's our cardiac arrest rhythms. That patient is going to die in the next few minutes if he's not already dying. Okay? If you don't know what to do then, you're on your own. You don't even have enough time to call. Most times, especially ventricular fibrillation. So I've seen some people that refer a patient diagnosed with ventricular fibrillation. I just, how can you diagnose? And you send the patient away. That paper you wrote will indict you. Okay, fine. So, good. All reading problems need to be seen by a specialist. Okay, so what reading is this? We are still on it. Yes. Let's give this man from FMC. What reading is this?
Okay, the RR intervals appear regular.
Perfect.
And the P waves there's a P wave before every QRS complex, but they are inverted in lead 2.
Okay.
And also in AVR is positive in AVR.
So we can see this is the opposite, Abi. It's inverted in lead 2 and it's positive in AVR. There's also a possibility that can happen if you misplace the lead. If you place the lead the wrong way, it can also give you that. So you have to be careful about that. But correct. Continue.
The P waves, they appear similar in the rhythm strip.
Okay.
And I think that's about that. But this is an abnormal reading.
We all do that one.
Likely atrial flutter.
How did you arrive at atrial flutter?
Multiple P waves.
So there are P waves without a QRS after. All the QRS have a P wave before, but not all the P waves have a QRS after. Do you all see it? So let's look at it together. For those that can't see. I'm afraid to climb this stage. I don't know how to hold. P wave, P wave, P wave, P wave, bam. Abi, can we see that? P wave, P wave, P wave, P wave, bam. P wave. So that AV node, very stubborn customs. You send something, they say they don't allow. Send something, they say they don't allow. Send something, they say they don't allow. Then finally, bam. So that is, it also has some kind of AV block. So this is a 4-to-1 AV block. You have to have 4 P waves before you allow 1 beat to pass. So this is an atrial flutter. Hello? I don't understand. I don't understand. I should go over it again? Good. Every time we're looking at the P wave, we look at the P wave on lead 2 and lead V1. That's how we look at P wave. If you want to study P wave, you look at it on lead 2 and lead V1. That's why you see I focus on there. We have QRS and there's P wave for every QRS. Can we see P wave before every QRS? But the P waves are upside down, meaning they're not coming from the correct place. Number 1, Abi? Hello? The ones coming from the correct place are always facing up in lead 2 and they're upside down in where? AVR. So here now, we saw QRS, then we saw a P wave, we didn't see QRS. We saw that P wave, we didn't see QRS. We saw that P wave, we didn't see QRS. Then we now saw P wave, then we now saw QRS. So multiple P waves before a QRS, even though it is regular, this is an atrial flutter. This is one of those formulas you need to cram. You will see it again. Atrial flutter. P waves, can you see that? Multiple P waves. If you get in heart failure, they will not get better until you solve that problem. Is it clearer now? All right. All right. Let's get harder. Does she may want to try? Try. Try never killed anybody. Well, sometimes, yeah. See her now, see her now. No, she may. Yeah, new. Just try. Start from beginning. Give her the microphone now. Give her the microphone. They will take your picture. That's the good part. All right. So very simple. What's the first question?
The RR.
Are they equal?
Yes.
Next question.
Then the second one is the P wave.
P wave in lead.
Upright.
Is it upright? In lead 2 and inverted in AVR.
In lead 2, the P wave is not upright.
What happened to it then?
It's downward.
Where is it?
At first. Okay.
So
there is P wave, but there is no QRS.
See the P wave.
Yes.
Can we see the P wave again?
Yeah, but
can we see the P wave again? Can we see the P wave again? Is it facing up or facing down?
It's facing up.
Good. We can't see it very well in AVR actually, so but we can see it there.
There.
Question number 3. After that one, every period, before every current is one, Abi. Question number 3.
All the QRS complex are preceded by R wave.
By a P wave,
By P
Abi.
wave.
Correct. And after every P wave, there's a QRS, Abi.
Yes, sir.
All the periods, do they look alike? At least the ones you can see.
Yes, sir.
Good. So what is the problem here? What is the rate here?
The rate
It's
I
like
think is
300 divided by 1.5. Abi, it's almost up to, okay, it's up to 2 boxes.
It's up to 2.
About
So I
2,
think it's
so about 150, Abi.
150.
Good. So this is a tachycardia. It's a tachycardia, but it's a particular type of tachycardia. It's a wide, complex tachycardia. Can you see how the QRS is wide? So let's look at the previous QRS. Can you see this QRS? Can you see it's narrow? It's less than half of a big box. A QRS should be less than half of a big box. This one, can you see the QRS? Narrow, less than half of a big box. Can you see this one, Abi? Less than half of a big box. Now let's go back to our own. This one now, can you see how wide it is? So this is a wide, complex tachycardia. Typically, we call this a ventricular tachycardia. What did we say about ventricular tachycardia? Emergency, wide, bizarre, fast, typically regular. You may or may not see the P wave. So you saw some price, you're not seeing the P wave. This case, because it's slower, you can see, a lot of times you will not see that P wave. You just see the QRS going pa, 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 pa. Do we understand? Do we understand? Let me go back to it. Anytime you see an ECG that is fast, heart rate is 150. First question, ask yourself, is the QRS wide or narrow? If it is wide, you are likely dealing with a ventricular tachycardia. And that is an emergency. You must not miss it. If not, you'll be part of that story of sudden death. All right, great. And then ventricular fibrillation, it looks like jaga jaga. But one thing you must make sure, it has happened before. The ECG electrode disconnected. And we say, we just connect. I look at the patient. Patient is alive now. Patient cannot be alive with VFib. They will be like this. Cardiac arrest is definitely happening here. Why? The ventricle is just doing like this, like this. So not enough blood is moving anywhere. So the person will definitely drop. Except they have a defibrillator. If they have a defibrillator inserted, like we typically put for our heart failure patients, immediately it picks this one, it will shock the person. Or when it picks the VT, because VT typically starts before it goes out. When it picks the VT, it will pace it at a higher rate than this and overcome it. So you get Mara, I will give you higher Mara. It will now go at 250, overcome it, and then bring it back down. That's one way. The other way, that will shock and come back to normal. Is it easy so far? Hello, is it easy so far? I don't understand. Please, our facilitators, please stand up. Please stand up. Let them see you. You can call them to your side. They can show you quietly one by one.
For the sake of those of us that are in this room today that believe an atrial flutter has something called the sawtooth appearance, can you help us out with that? Because that's not the way the P waves, you have shown them out. She had to explain something to me now as regards the fact that atrial flutter can either be slow or be fast. So please, can you shed light on that?
So, if you want to see that sawtooth, look at that V1. Does it look somehow like sharp teeth? Can you see that V1? Does it look like that a bit? So in sometimes to be like that. So when you are seeing that sawtooth, more in V1, you see it like that. Okay, and then it could be faster too, and you see it. But don't think like that. Forget that mindset in your head. Think the heart. And think that P wave, QRS. And now anytime you see multiple P waves, which is that sawtooth, you have a QRS. That's all you are looking for. Anytime you are seeing multiple P waves before a QRS, you are thinking atrial flutter. When you think sawtooth, you will see sawtooth once in a long time. So what normally happens, they will refer a patient. Patient is not getting better. In fact, some other cardiologists, patient is not getting better. Well, I'm giving this. I said, bring the ECG. It's normally more subtle than this. You will just look, you will see it there. Why do I know it? I failed it before. My guy laughed me to scorn. He laughed all of us with all SRs. And I was the chief guy. I said, sir, no. He just started laughing. And my guy does not teach. He laughs. You will find the answer by yourself. So that is how I now picked it. I never forgot it again. So same thing here. If you look at this thing, put it in your heart. You will go back now. Some of you will go back if you have your ECGs in your facility. In Limit Hospital, we must have over 50,000 ECGs. If you go through inside there, you will find MIs. You find people that have died and you check their case file, you will see the people that had MI. I had all of these things. Nobody just saw it. So we now say it was sudden, and the man was fine. He was doing fine. In fact, he just greeted his people. All right, great. So let's move a little bit faster now. So we have different kinds of AV block. AV block. Remember the AV node. What do we say it is? Customs, Abi? AV node is where? What does it show on the ECG? How does it show on the ECG? Good. If you get distracted by Instagram, you are your own. Don't come and ask me, because I can see some people touching phone. When you ask questions, I'm not going to answer you. Me, man, I'm going to look where? Your side. You have 90 minutes to stay off anything. So, the first type of AV block is called... Hey, what did I miss? Where's my first type? I didn't put this here. Uh-oh. Uh-oh. Well, the first type of AV block, this is not it. It's just a prolonged PR interval. When that PR interval is prolonged more than one big box, we call that first degree AV block. It's not this one. Let me see if I have it. Oh, shit. This PR's interval, from the point of starting from the P wave, beginning of P wave to the beginning of QRS is the interval. This is the segment. This is not where you are measuring. You are measuring the interval. From here to here should be one big box. One big box. QRS should be half a big box. Remember it. PR should be what? One big box, right? QRS, don't get tired of me. We never start ECG. We just sit there and do warm up. We never really have time. Don't get tired of me. Me, I don't tire. But anyway, maybe you're ready to take over, Abi. Because I'm feeling woozy. Maybe not food I need though. Alright, PR interval, one big box, QRS, half. Okay. QT from beginning of Q to T wave. What is the normal QT? It should be less than half of the RR interval. QT should be less than half. So from this R wave to the next R wave, QT should be less than half of that RR interval. This is important. In people that have a long QT, there are certain drugs that will cause them to have sudden cardiac death. Certain antimalarials, halofantrin, even queries sometimes, some people wonder whether lumefantrine in coartem could cause those people to decompensate. Quinine, those kind of things. There are many drugs. So in those kind of people, when you get their ECG, they have a family history of sudden death. When you get their ECG, one of the things you are looking for is the QT. They have what we call a long QT syndrome. This QT will be longer than half of RR interval. Write it down. We're going to use this to interpret ECG. Remember, there are so many formulas. So I will now show you how we use the formula. It will be thing go sweet later. Now it go hard. All right. Have I finished that? I think so. So now we're on QRS, Abi. Step 4, QRS. Oh, I didn't go to the AV, Abi. So I said first degree AV block is simply that what? PR interval is prolonged more than one big box. For second degree, we have two different types of second degree. The first one is called the type 1 second degree or the Weckenbach. And in this one, it is first prolonged. Can we see it prolonged? But the next time it gets more prolonged, the next time it gets much more prolonged, and the final one it does not beat. So can we see the period on the final one there? Let me climb this stage. Can I climb like this? Let it not be on news that I fell down. All right. So we can see the PR from here to here, right? From here to here, is it longer than this first one? From here to here, is it longer than the second one? Then finally a P wave came and nothing came. So it is like a husband. The first type 1, first degree AV block, the person comes late home every night, 11 p.m., but every night shall go come home. I know one man like that. His jazz is that whatever happens, he must sleep in his house, no matter what happens. So every night, 1 a.m., he will be there. He will never sleep anywhere else. In this one, he tried first. First night, come by 11, madam, no talk. Abi? Next night, 1 a.m., madam, no talk. Next time, 3 a.m., madam, no talk. The next time, you don't come home at all. Type 1, second degree AV block. Do you understand? Don't forget it, or forget my joke. Don't forget it. This one, as you are seeing it, you'll be able to predict. The one that comes at 11 o'clock, you can predict, Abi. This one too, you are seeing, you can predict. Now it now gets worse. This type 2, all of a sudden, he was coming home. Then all of a sudden, one day, just no come home. This is what that cost him more heartache, Abi. Because you are expecting him. You don't know which night he will not come home. Abi, type 2, second degree AV block. So we have first degree AV block, which is what? Hello? Prolonged PR. Come home but late. Type 1, second degree AV block. Increasing, Abi, increasing PR until finally it no come at all. Type 2, second degree AV block is prolonged, but occasionally it just drops. It just drops a bit. So just drops the QRS occasionally. And then third degree AV block, there is no relationship between the QRS and the P wave. The P wave is going at a steady rate. Can you see it? It's almost equal, Abi? P wave is going equal. QRS too is going equal on its own. There is no correlation. This patient needs a pacemaker. Dual chamber pacemaker. So what we do typically, we put an MRI compatible dual chamber pacemaker, takes about 30 minutes to 90 minutes and it's all over. Okay, and the patient gets back a regular rhythm. We put one lead in the atrium to beat the atrium, another one in the ventricle to beat the ventricle. Good, so complete heart block. Do we understand this? Type 2, they are occasionally dropped ones, but there is still some relationship between type 2. In this one, there's a P wave, there's a QRS. There's also another one here, P wave QRS. Then here you just have P wave, no QRS. In type 3, the difference here is that P waves are going on their own. There is no relationship. So, but typically, sometimes it can be difficult to differentiate the two of them. You will need a much longer strip to be able to do that, because you can think that, okay, maybe these are just drop bits, Abi, and that this one may be still related. But when you see a longer strip, you will see that, both of them are doing their own things separately. Okay, so sometimes it can be difficult, but typically, they are all related. This is a complete heart block. You need to recognize this, especially when the patient has a slow heart rate. So somebody collapses, suddenly you check their heart rate, you are getting 30, 35, you're not sure that it's your hand. You need an ECG. You should be able to tell the difference between all these three on that ECG. All right. This ECG, who can tell us what they are seeing on this ECG? Anybody? Anybody? Somebody? Save me. Okay, what's the rate? What's the rate? About 50, Abi? More or less. What's the rhythm? What's the rhythm? It's not regular and irregular, that is pulse. Here we say sinus or not sinus. And when we say it's not sinus, we have to say what kind of not sinus it is. So, is it sinus? No. So, you said it's not sinus. So, what is it? We now have one of those AV blocks, Abi. In this case, we have two rhythm strips. Very important in this kind of case, so that you can look at it very well. So now, we now saw P wave. Let's start from here. P wave, QRST. P wave, QRS, another P wave, another P wave, another P wave. It's not following. Under P wave. A small QRS. Under P wave. Under P wave. So the QRS and the P wave don't seem to have any relationship. Is it getting longer or shorter? What do we think? There's no relationship between two of them. This is a 3rd-degree AV block. Doc, do you agree? Do you agree? If you don't agree, talk. Anybody doesn't agree? Anybody does not know what they are seeing at all? It is still looking like Jaga Jaga. Okay, thank you. At least you're not looking like Jaga Jaga yet. Thank you. I've made some progress. Remind you, there's not all ECG you'll be able to interpret. Even amongst us, there are ECGs we still have to send. Oh boy, what do you think? Oh boy, what do you think? Oh boy, what do you think? What do you think? What do you think? Nobody's an island. There are still some ECGs that you still have to calm down. And this thing I'm teaching you, I will have to go through it myself. Only that I've done it so many times that it's in my head. So, the other thing we look at on that one, we look at this QRS. Is it wide or narrow? Narrow, Abi. So beautiful. Very important. So, a narrow one is 0. That is less than half a big box. Okay, I will not talk about this one. Now we come to this thing called bundle branch block. Bundle branch block. Bundle branch block. Do I have an ECG? Do I have a picture of the hearts? Okay. What do we say QRS is? Correct. And that corresponds to what time? When the electrical activity is going from where to where? Not from the atrium, from the AV node. Customs, Abi? Good. So if there's a blockage along the pathway spreading across the ventricles, where will we see it? QRS will be what? Prolonged. So when QRS is prolonged, we say that there is a bundle branch block in most cases. Now we'll now differentiate 2 types of bundle branch block. There's 3 actually, but we'll differentiate 2. The first one, we look at V1. And in V1, it looks like an M. M. While in V6, there's a big V or W. You will see this thing tire if you are going to do US exam, US licensing exam. Okay? So you see this M, and then you see this V. You can't even become a nurse abroad. You can't know how to do DCG. All these other people are doing here, grand like this. Okay, so you see the M, and so this is a now for a left bundle branch, however, this thing is inverted. In V1, we have the big V, while in V6, we have the M. So, William, W-L-M, William, Abi? That is that up to tomorrow, I still have to remember this William to differentiate it. And Marrow, M-R-W, Marrow. Hello? Can you see my mnemonic? Does it work? It's not my mnemonic. It's an international mnemonic. Everybody uses it all over the world. M-R-W. So this one looks like M in your mind. This one looks like V-R-B or W. Marrow. So this is right. But this is how you differentiate right from left bundle branch block. Keep it in your mind. So let's look at this one now. The QRS, is it prolonged? QRS, is it more than half of a big box? Is it more than half? Hello, Toko. Those at the back. Una dey here, so. You don't already come, no problem. Learn. Just talk. From here to here, is it more than half of a big box? Correct. So it's prolonged. Now we know that there's likely something blocking the passage on that QRS, going around the ventricles. Question number 2. Is this a right or a left bundle branch block? Those for APC say left, those for PDP say right. Well, you're just joking. What do we say? The one that has M in V1 is what? Marrow, Abi. So this one M, Abi. Perfect. It's M now. See M now. Pam, pam. It's an upside down M like that. And the one that has a big V in V6 is which one? Marrow. Right, Abi. So this is a what? Right bundle branch block. Hello, I don't understand. Raise your hand. Fine. Let's go back. Can you see this one? Right bundle branch block. V1. Can you see it has RSRM pattern? Can we see that? Right bundle branch block, Abi? While in V6 it has a V. Can we see that? Now, look at this one. What are you seeing in V1? Does it look like that? What are we seeing in V6? Does it look like that? Does it look like that? Perfect. So that is how we arrived at it being a right bundle branch block. I still don't understand. I need spiritual help. Okay, somebody's going to you. Somebody's at the back there. Please, Dr. Adefila, just go to the back. Back, say your hair good. Help me explain there. I don't understand. I need one-on-one. Just somebody, just raise your hand, please. There's another person there. Dr. Taiwo, there's somebody there behind. So, what did we say about bundle branch block? Number one, QRS is prolonged. Abi? Simple. Number two, where do we check? V1 and in V1, what are we looking for in the QRS? It looks like M. In this case, does it look like M somehow? And in V6, it looks like a V or W. What does it look like? So this is a right bundle branch block. If it was left, how will it be instead? Correct. This V will be in V1, while this M will be in V6. Now, if you have chest pain, which one does it look like? If you have chest pain and a new, is it right or left that may look like STEMI? Left, Abi. So you must recognize that left. In right, however, if somebody has a PE, somebody who had a number and not see a new right bundle branch block, most likely you'll be thinking of a pulmonary embolism. Okay, so very important to look at that. So still on the QRS, should we do this one? Should we do this one? Should we do this one? Okay, let's do it. Still on the QRS, we can see whether the different chambers of the heart are enlarged. Remember, we have right and left ventricle, Abi? Just follow me, we will soon be done. If you are writing and following me one by one, we will soon get to the point where everything will make sense. Just trust me. I've been doing this for many years. I have many graduates. Just trust me. You would believe in me, at least. So we want to determine whether there's a right ventricular hypertrophy or a left ventricular hypertrophy. For a right ventricular hypertrophy, all we are looking at, forget that if there's a QRA, if there's a bundle branch block. For a right ventricular hypertrophy, all we are looking at is at V1. This V1, is it predominantly facing up or facing down? Anytime V1 is predominantly facing up, except the right bundle branch block, it is called right ventricular hypertrophy, meaning that the right ventricle's wall muscle are thickened. Hello? I don't understand. Okay, good. When we look at, let's go to previous ECGs that are okay, this V1, is it, or this QRS in V1, is it facing up or facing down? So is there right ventricular hypertrophy? Perfect. You can see it's simple like that. So let me see if I can find correct. I can see one. Okay, this is still right bundle branch block. Okay, Sha. But what we are looking for, just like as if it's in that right bundle branch block, is that once the Q is facing, is it facing up or down? Up. So assuming there was no bundle branch block, once you have an upright V1, we are saying there's a right ventricular hypertrophy. That's what it is. Okay. Just write it down. Cram it first. We will see it very soon. So number two thing, now we want to see the left. Left ventricular hypertrophy, typically in patients that have hypertension. You will see this one a lot. And what we are looking for is that when we combine the R wave, remember it's PQRST, Abi, in S wave in V1 or V2, and R wave in V5 or V6 greater than 35. What did I write here? Together, Sha, greater than 35. Or any of them greater than 25. 35 means 7 big boxes. 25 means how many big boxes? 5 big boxes. So let's look. Oh, let me look back. Okay, Okay, good. Let's use this one. So let's look at this one. Is there a right ventricular hypertrophy here? Is there a right ventricular hypertrophy here? How do we know? V1 is what? Not is facing downwards, Abi? Beautiful. Is there a left ventricular hypertrophy here? How do we know? We come to V1 or V2, right? And we look at their S waves. Can we see the S wave? Is it S wave, Abi? How many boxes? Let's call these 2 boxes, Abi. 1, 2. This is the longer one. Then we come to V1 or V6. Which one is longer? This one looks longer. Let's add this one. 1, 2. Let's even give each other 3. 3 plus 2 is what? How many do we need? 7. So there's no left ventricular hypertrophy. There's no right ventricular hypertrophy. Is that simple? It's not simple. It gets simpler. But you understand it, yeah? You don't understand it. What don't you understand? Hypertrophy? Huh? I should repeat it, Abi. So I want to determine whether this is a right ventricular hypertrophy. I will look at V1. If V1 is facing upwards, I will say it is what? Right ventricular. Is this V1 facing upwards or downwards? So there is no right ventricular hypertrophy. Now for left, this one that is facing downwards in V1, normally in V2 is also facing downwards. This one that is facing downwards, I will come and count the number of big boxes. How many big boxes is here? 2. I will come to V5 or V6 as well and see the ones that are facing upwards and count the number of big boxes. Then I will add them together. This big box plus this big box, the total is what? 5. If it was more than 7, I would say there's a left ventricular hypertrophy. That is all. People that have left ventricular hypertrophy are at more risk for sudden death, especially when they have hypertension or other things. Is getting clearer or getting worse? All right, we're getting to the end. We're getting to the end. ST segment. ST segment. What do we say about segment? For segment, do we look at time or whether it's up or down? Up or down, Abi? Devil is a liar. Devil is a liar. Yeah. No signal. Aha, thank you. All right. What did we say now? Segment. Yeah, segment. So segment, we'll look at whether it's up or down. I will look at the J point. J point is typically the point where this meets here. Typically, we'll take a small area, one small box in front of here. That's where we'll decide, is it up or down? We compare it with this line, right? And we'll use that to determine. And I've told you about contiguous leads. What did I say about contiguous leads? Leads that are facing the same area, Abi, and that you need 2 areas to agree with you. Is that what we said? So good, we're done with that. I'll jump here. I'll jump here. Okay, can we see this ST? Is it elevated or depressed? So this is the line, Abi, TP line. From here to here, how many? That's 5 small boxes, Abi. That's 1 big box. So that is definitely elevated. But we cannot take the voice of 1 person. We need at least 2 people, Abi. That's what we said. Who else must agree with V2 for us to say that it's true? So go to V1. Is they there so? Then we say that V3 and V4 are neighboring partners. They normally agree. Niger and Nigeria. Okay? Do we agree? No, I don't think so. So we come to V3 and V4. Are they also elevated? Correct. Then we look elsewhere. We can still see 2. If we see in 2, which other ones? What are they? What group of those are they? Inferior. Hello? I don't know. Check your previous note. We wrote it before. 2, 3, AVF, inferior. And I told you to cram it. I told you to cram it, Abi. Because if 1 person is talking, it's not enough. We need other people in the same area to say, yes, this tax bill no correct. Abi? Najoko, I beg. Please, I beg. No God demolish this place. All right, remember this. Remember when I showed you this, Abi? So it's the same thing now we are talking about. So now, let's look at this ECG. This man, I remember this man. Very slender, athletic NSCDC man. 2017. Yes, I remember him. From my place. I said, there's nothing. If not for this thing that Dr. Adifila told you, that everybody with chest pain must have an ECG, including you. Don't say that your own is different. My professor has died. That's why he sat down for house. Says also I was drinking. When he came, he did not last 10 minutes in the ER. So including you, if you have chest pain, you must do an ECG. So we look at this ECG. This guy said there's nothing. I said, but just since it's the protocol, let's do it. What can we see in this ECG? What's the rate here? What's the rate? How many big boxes are there? Don't get tired of me, oh. Me, I don't tire. How many? 4. 300 divided by 4 is what? Beautiful. What's the rhythm? Rhythm. Is there P wave before every QRS? Are the R intervals equal? After every P wave, there is a QRS. All the P waves, they look alike. Yes, they do. This is very big, so you are seeing even the minutest differences. There are small differences. Body brand block. Is there right ventricular hypertrophy? How do we know? V1 is it up, right, or down? Down. So there's no. What of left ventricular hypertrophy? There's nothing here going up, anything serious. So here, 1, 2, 3, 4. So, go pay. Abi? Is my Yoruba correct? Almost. All right. So, no LVH. Now we'll come to the ST segment. ST segment. Any ST segment elevation? Any ST segment elevation? So, look at this line here. Can we see the line? This is the line, Abi. Going here to here. From here to here, is there some elevation? Yes, one small box. Same thing here, up. From here to here, is there an elevation? Small, very small. Very small. We can see in V2, we can see in V3. We can't quite see, V1, 2 is there to Abi, 1. If we have seen in V1, V2, V3, where are we looking for next? V4, not very well, but it's there, you're hardly there. Let's look at other places, any other place. This is the 3. Get us a B, Abi. Let's put our line. See our line coming like this. Is it above or below? So there's some smallest elevation here. If we see in V3, which other brothers are we looking for? 2 and AVF, Abi. In 2, there's nothing quite there in 2. What of AVF? Is there? We need only how many people? 2 or 3? 2 at the voice of 2 witnesses, Abi. So there is something there. So automatically, we are saying something is affecting anterior, septal, and inferior. That is bad. Because this inferior is right coronary artery. This anterior and septal is left coronary artery. We already know it's extensive. So, at that time, we're not doing cath, and I don't know anybody doing cath. I said, oh boy, this is not touch and heal. This is bad. She went to a triple vessel disease. Everywhere was blocked. Everywhere. She refused surgery and waiting for something to happen. It didn't happen, and she went home. Okay, unfortunately. But once I saw this ECG, you can tell that multiple places are blocked. Now we now come and now look at the Q wave. Is there Q wave here? Q wave, we just talked about Q wave. What do we say Q wave is? First negative deflection. So we have P wave there. Is there anything going up there at all? So that's a Q wave. Isn't that not a Q wave? First, is there a Q wave here? V1, V2, V3 also, does it have a Q wave? If there's V3, there's Q wave and V3, where else are we looking for? V4, same thing there. Let's look again. This lead 3, get us a BRB, almost. Huh? And AVF also, almost. So we are seeing Q waves. Okay, very important. And finally, is T wave. For T wave, we're just looking whether it's up or down. Normal T wave should be up. Like in that lead 2, can we see the T wave going up? Lead 3, the T wave is up too, Abi. Lead AVF, T wave is up. What about here? Where is the T wave? It's facing down, Abi. Also for T wave, you look for those brothers, Abi. Now we are finished. We have read all the ECGs. Let's now go to practical. T wave up or down. So let's start. Can somebody interpret this ECG? Correct. So this is the line, Abi, the TP line. So when we come like that, this is below, Abi. And it's also there in V3, in V2, V3, V4, V5 self. Abi? Some, not really in V6, but from almost from there. Is there any Q wave? No Q wave, Abi? What about the T waves? Inversion where? It's upside down where? From V1 all the way to V5. Correct? Beautiful. So we have right ventricular hypertrophy with a lot of strain. It's so big that the blood supply to it is reduced. That is why we have that T-wave inversion, all because of that right ventricular hypertrophy. So I see this one, either there's pulmonary embolism, pulmonary hypertension, something is wrong there. Great. Thank you very much. Did you not see? Good. Clap for her now. I'm going to bring back to you. If you're not clapping, just know that. Yeah. See how they clap. Be fair of Mike. All right. Again. P wave in lead 2, is it upright?
Yes.
Is it upside down in AVR? Good.
Yes.
So what we have actually is that we have occasional ectopic beats coming from the ventricle. And you can see they don't look alike. Like we said for the atrial one, Abi. So it's coming from different parts of the ventricle. Different people are coming to play away match. Right? Is that what we said? So we have this one looking like this with oblong head, sharp head, upside down head. Abi? Different types of ventricular ectopics. They are all coming from, QRS is what? Ventricle, so it's coming from the ventricle. If it was P wave, the last one, that's why we said it was atrial. While this way is QRS, that's why we said it's what? Ventricular. Beautiful. So what we have said now is that this is actually a sinus rhythm, but with ectopics. With multiple multifocal ectopics. Multifocal, multiple places, Abi? Multifocal ectopics. Good. So we have the rhythm, we have the rate. What is the PR interval far? From beginning of P wave to the beginning of QRS, is it more than one big box?
No.
So normal PR interval, Abi?
Yes.
Then we go to what? QRS. QRS, is it wide? What is a wide QRS interval?
More than half.
Is this one more than half of a big box?
No.
No. So, no. Now we now come, is there right ventricular hypertrophy?
No.
No, Abi, because V1 is facing which direction?
Down.
Is there left ventricular hypertrophy? 1, 2, let's call it 3 plus 2.5. No. It's not reach 7, Abi? Fine. Yes, what again? ST. Is there any S elevation or depression? Any S elevation or depression? Now, when you are looking at S elevation or depression, don't look at the ectopic beats. Do you get it? So if you are looking at it and look at the ectopic beats, it will mislead you. So forget your mind on the ectopic, look at the other beats. Okay? So those of you that are calling AVL, that's an ectopic beat. You can see it across all of them. It's an ectopic beat, just looking different depending on who is talking about it. So look at the other one on AVL. That's one bit on AVL, that's another bit on AVL. There is nothing there. So there's nothing on AVL. Okay, so there's no, is there any Q wave? Again, don't look at the QRS, at the ectopic. Is there any Q wave? Anybody? Oh, the house is getting quiet. All right. Is there right ventricular hypertrophy? No, we said no. Is there left ventricular hypertrophy?
No. We
said no. No acceleration, no T-wave inversion. So what is the final diagnosis? It's almost normal, Abi, except that you have multifocal ectopics, ventricular ectopics. You must say ventricular because you know where it is coming from, Abi. Beautiful. You have to read it now. Physiotherapists, what are your name again? Chijoke. All right. What about this one? I think we've done this one before. What about this one? Let me look for something harder, Jenny. Oh, hey, give somebody this one. Yes, you want to answer? Give her, let her answer. This is ECG. Good. Ask. This one? This one?
No, the next one. So for the main, for the QRS complexes that came from the sinus reading, that came from the
Perfect.
sinus P wave,
Correct.
they actually, their sizes actually look abnormal. And from the rates, does it look like there's actually a block happening somewhere that's causing an ectopic ventricular discharge?
That's a very good question. So sometimes when the rate gets too low, the ventricles take over and start throwing. Truly, it's possible that the rate going too low. So the ventricles say, what's happening there? Let us also find out. So they start throwing beats by themselves. It's very possible. That's true. So that's possible. But this one, yes, they're actually low voltages. So we define low voltages in QRS as if the total QRS is less than 1 big box in all of them. So all of these limb leads, we call these limb leads, the normal ones, all of them are less than 1 small box. So we say they are low voltages in the limb leads. Low voltages is defined as, write it down. Low voltages is defined as when you look at them as either chest leads or limb leads. In the limb leads, that is these ones, 1, 2, 3, AVR, AVR, AVF. If they are less than 1 box, if all of them they are less than 1 big box, we call it a low voltage in the limb leads. However, in the chest leads V1 to V6, if they are all less than 2 big boxes, then we say it's a low voltage. Again, in the chest leads, this one that we are seeing, all of them, they are all above, except V3, Abi. They are all more than 2 big boxes, Abi. Their total span from QRS is more than 2 big boxes, Abi. While in this one, their total span, all of them are less than 1 small box. So we say they are low voltages in these limb leads. We will forget about this ectopic. Don't look at this ectopic. Look at the other ones that are normal, and that is a low voltage in limb leads. I will never forget, we were doing world round, maybe 2013 or so. Surgeons were putting pressure on us. You know how surgeons will put pressure. Sign this ECG. They want to go to a surgeon. The surgeon say you must sign. So the surgeon normally used to insist that a cardiologist must sign so that they know who to head to hang. We shouldn't die inside. So they were putting pressure. My friend was the SR there. He wrote that he can see low voltages in limb leads. They say, right, that is okay for surgery. He said, how can I say it's okay for surgery based on it? They put pressure on him. Professors were calling. He said, so we said, okay. Before we started, let him bring you for echo. That person's ejection fraction was 20%. That's how they cancel the surgery. You will have signed, and the next thing, you'll be in front of panel, explaining why you should still have a license. So while it looks innocuous, it can be extremely, because what it means is that that heart muscle may not have enough mass again. That is why it's not bringing up enough electrical activity. You know when low current, this exactly, low current, low voltage, now be this. How your bulb when they do like this, now be this. Okay? Occasionally, the transformer go vex, boah. Then otherwise, it go rain low voltage. That's what we're talking about here. So when we see that, several things can come to mind. Person may just be too fat, but sometimes person may have pericardial effusion, fluid around the heart, or different other things, or the heart muscle is not working well. All right, I think we have done a lot of justice to all of this. We have a lot of practice ECGs in that book. So if you go to the back of the book, you will see an algorithm to learn the ECG. Then we have practice ECGs. You have to make sure you answer all of them. Don't wait till tomorrow. By tomorrow, you will have forgotten. I assure you. Don't wait till tomorrow. Answer this one. Look for any ECG you can find and keep on answering. Otherwise, by tomorrow, you will forget. By Monday, it's all over. You'll be asking what is P wave. I am telling you. By next week or by New Year, you will not even know what ECG is. I'm not joking. This is exactly what happens. But a few of you, 5% of you, normally it's not more than 5%. The rest of you are just joking. But you prove me wrong, Abi. 5% of you will take this one, answer all the ECGs, go to your clinics, find other ECGs. The remaining 1% will do that and find other people and teach them. Then they will also send some ECGs to our WhatsApp group that we have created, Abi, and say, sir, I have this ECG. This is what I thought it was, but I'm not sure about this. Those ones, by next year, You see them on their table teaching other people. No. Nah, this is how it is now. So the next 10 years, that's what they go do. Give him now. See him now. Sharon, it's your time to shine. Where is Sharon?
Hey, she knows it. She's here.
I didn't say she read ECG. Come on, prepare your slide, Gary. I read ECG. All the dietitians in the hospital, they used to read ECG. There was a time even all the admin clerks, the health records, they read ECG. That's how it used to be before. Then they almost reach cleaners, started reading ECG. That's how easy ECG is. I'm telling you, once you can see, it's not anything more than up and down the number of boxes. Once you can count and you can read ECG. Oh yeah, thank you, ma. Go ahead. You agree now? We have demystified ECG today. Anybody who know them, tell them they give a national award. Please go ahead now.
I would say the rhythm is regular and the heart rate is 75. Then sinus and the RR interval is regular and the heart rate is 75 beats. The PR interval is not prolonged. And the QRS2 is not prolonged. There is no right ventricular hypertrophy or left ventricular hypertrophy. The ST segment is elevated in lead 2, 3, and AVF. I'm not seeing any Q waves or this is inferior MI.
My time was not wasted here. At least one person, I'm sure. Oh my God, I feel happy. Oh, I feel happy. Are you married? Let me look for a husband for you now. All right, thank you all very much. I hope you've been valued for your time. We have demystified it. It's easy.
It's a round of a quick happy for him now. Is it easy to